Hey everybody, this is Eric with FlightBridgeED and welcome back. We're going to start on part 3, so it's going to be actually podcast 5. It's going to be part 3 of the ventilator management or ventilator management in the EMS world podcast series. We've done, again, part 1 and part 2. Part 1 was basically on oxygen physiology, aerobic and anaerobic metabolism, and we went through the different terms as it's related to ventilator management: tidal volume, respiratory rate, pressure support, plateau pressures. We talked about all those little aspects of ventilator management just to kind of get an idea of what all that means. In part 2, we went into the modes of ventilation. We talked about 3 or 4 different volume modes, and we talked about a couple pressure-driven modes. And we talked about why we would utilize each one. We talked about benefits, and we talked about things such as problems with each mode. In part 3, I'm going to kind of put all this together, and we can have all the knowledge we want in all these different modes of ventilation and the terminology, but we need to understand how we apply this to our patient care. That's the biggest deal, and that gets really confusing. We have patients that have different presentations, and we can make massive changes with our patient as far as patient outcome if we do things correctly, but we can also make them very sick using your ventilator if you don't do it correctly. So like I said in podcast 1, I learned this strategy from another podcast, a wonderful teacher, MD, that does a great podcast series called mcrit.org. And I listened to this podcast about 3 years ago, and he talked about an ARDSNet study approach, and I elicited to that early on in podcast number 1. The ARDSNet group is a group of researchers, MDs, that have done randomized trials that look at strategies to decrease the incidence of ARDS and ventilator lung injury. So I'm a big believer of it. If we can have an approach that actually limits ARDS, that's a horrible disease process, very high mortality rate. If we use that same approach on our patients, we're going to really limit that from happening to them. So that brings me to how do we approach our patients? And he laid out this excellent approach. I applied this to my clinical practice as a flight paramedic and have had great results. It's very easy to understand. It's very easy to follow. So I'm going to break it down into 2 different approaches. There's going to be a lot of numbers thrown out here. I'll try to talk really slow when it comes to this. Try to take notes, follow along, because the strategies that I lay out here should make sense. And it really did make me look back at how I approached minute ventilation and how I was probably hypoventilating my patients. And one thing that I've realized and recognized as an educator in the HEMS world is, a lot of flight crew members have a hard time with maintaining a good end-tidal CO2 level. We're taught to maintain that in the 35 to 45 range. Obviously, we have very sick patients, and I hear it all the time. Their CO2 kept climbing. I couldn't get it to drop down. Well, I'm going to lay out an approach that's going to hopefully help you understand why that may have happened and how we can prevent that from happening again. So the 2 different approaches. I'll start with to talk about the obstructive approach. So you have an injury approach and an obstructive approach. The reason why I'm going to start with the obstructive approach is just to kind of weed out this side. Obstructive approach only utilizes asthma and COPD exasperation patients. That's it. All right, so that kind of gives you an idea. Everything else, every other patient presentation, every other etiology, whether it's ARDS, pneumonia, just a generalized sick person, trauma patient, etc., they're going to be under the injury approach. All right, so that right there breaks things down very simply. Obstructive approach for asthma, COPD, injury approach for everybody else. All right, so let's first talk about the injury approach because it kind of encompasses more of our patients that we see. All right, so I'm going to break this down slow again. Remember to try to take notes. I'm going to throw quite a few numbers out there. I'm going to refer back to different numbers, and obviously it's a little difficult for me to answer questions on this podcast. I do, again, if you have questions, if you have comments, please email me at eric@flightbridgeed.com, and I will definitely refer back to you and answer as many questions as I can. So the modes of ventilation that we can use for this injury strategy, we can use all of them. We can use assist control, we can use SIMV, we can use pressure control ventilation, or even PRVC, which is the pressure regulated volume control ventilation. With each one of these approaches, you're going to hear me tell you that there's a protective strategy with these. And with the injury strategy, tidal volume is your protection. All right, so what do I mean by that? Well, injured lungs are baby lungs. Injured lungs are weak, they're fragile, and remember what I've said in the ARDS study. High tidal volumes of 10, 12 mils per kilogram have shown that is brings very poor outcomes to our patients. So with that, they did the studies where 6 cc's per kilogram of for your tidal volume really reduced morbidity and mortality. So with this injury approach, we want to have very low starting points for our tidal volume, and so that's where we get tidal volume equals protection. We don't want to overinflate those baby lungs. We don't want to cause barotrauma or atelectasis trauma in our lungs. All right. So again, remember that we're not trying to fix a ventilation problem either. With this injury approach, unlike obstructive approach, where in the obstructive approach you would have a ventilatory failure where you have a CO2 level that's out of control, in this injury approach it's probably going to be an oxygenation problem. Okay? So we want high concentrations of oxygen, we want to be maybe somewhat aggressive with our PEEP, and we want to try to oxygen our patients as best as we can. All right, so where do we start on our tidal volume? Well, we start at 4 to 6 cc's per kilogram based on ideal body weight. Okay, and I always tend to start at the 6 cc's per kilogram. It's a good starting point. It doesn't give you very high tidal volumes. So for the purposes of this lecture, we'll use an 80 kilogram patient through all this math that I'm going to start talking about. 80 kilograms. So if we had if we started at the 6 cc's per kilogram of ideal body weight, your starting tidal volume is going to be 480 milliliters. Okay? The second thing we want to make sure is we want to always look at our plateau pressure. Remember I said in podcast number 2, I believe, where plateau pressure is your most sensitive number. It tells you what's going on at the alveolar level. It tells you alveolar health. And so we want to maintain that at 30 or below. So that's extremely important to get a baseline when you put them on the ventilator. Do that inspiratory hold, which is a half-second inspiratory hold on the inspiratory hold button. If you're using a Ravel ventilator, there's a button at the very bottom, and it's called manual, and you're going to use that button to do that plateau pressure. Okay, so we get a baseline plateau pressure. That's going to tell you what's going on at the alveolar level. Now at this point, we have to figure out how are we going to maintain eucapnia. And so remember, we have our starting tidal volume at 480 mils, okay? And we need to figure out what our respiratory rate is. So I'm going to kind of back up here. You or I, right now sitting here, we use 60 cc's a kilogram a minute of O2 consumption. All right? And basically what that calculation right there is a way to decide or figure out what our minute ventilation is. So if we take that 80 kilogram patient, and you times that by 60, that's going to give you 4.8 liters a minute of minute ventilation. And we know that the standard minute ventilation for you or I sitting here is anywhere from 4 to 6 liters per minute. Okay? We learned that way back in EMT school or nursing school that that's the standard minute ventilation. Well, one thing that we don't have that an intubated patient does is we don't have dead space. Okay? We have a little bit. We don't have the amount of dead space that an intubated patient does. And so with an intubated patient, you have the dead space in the ET tube, you have the dead space in the ventilator circuit. And you lose approximately 100 to 150 mils per breath in that circuit. So if we use a easy calculation for easy math, if we used a patient that you were giving 10 breaths per minute on your respiratory rate, and you times that by that 150 mils, you're losing 1,500 mils or 1.5 liters of oxygen that we should be getting to our alveoli. And so if you took that same patient that we referred to before, you or I, that was at 60 cc's a kilogram a minute, so remember that's going to be the 4.8 liters per minute of minute ventilation, and you minus 1.5 from that. So what is that going to be? 1.5, 5 minus 8, so it's going to be 3.3 liters per minute of minute ventilation. That's what our alveoli are seeing. So that's what's called alveolar minute ventilation, and you're going to hear me refer to that many, many times, because that's ultimately what we want. We want to make sure that we're getting adequate minute ventilation to our alveoli. We can put all the minute ventilation we want in, but what is happening down at the alveolar level? Okay, so always be thinking of that. So how do we compensate for that? Well, there's a calculation, and you're just going to double that initial minute ventilation calculation that we first talked about for you and I. So for you and I, we're at 60 cc's a kilogram a minute, and for an intubated patient, you're at 120 cc's a kilogram a minute. Okay, so if we just double that minute ventilation of O2 consumption for that intubated patient on that 80 kilogram patient, you're needing to have 9.6 liters of minute ventilation for an intubated patient. Okay, and we're going to do some simple math. So write down 9.6 or write down 9,600 mils, and you're going to minus that same dead space that we figured out before on a 10 breath per minute respiratory rate. You're going to have to minus 1,500 mils from that. Okay, so that's going to give you 8.1 liters or 8,100 mils of minute ventilation per minute. Okay, and that's excellent. That is great. That's what we want. We need that to maintain eucapnia. And yeah, it is a little bit on the high end, but remember, a patient's sick, they have an increased oxygen demand, their metabolic rate is high, there's different problems. We want to make sure we optimize oxygenation. Remember, oxygenation equals cardiac output, and that's the whole principle of the Fick principle. All right? So let's recap. We have 120 cc's a kilogram a minute. We have an 80 kilogram patient. We've already decided that 80 kilogram patient on our starting range for our injury approach is going to be 480 on our tidal volume. So we have all the numbers. We just need to plug in now. So we need to figure out what our respiratory rate is that's going to give us proper eucapnia and give us that minute ventilation. Remember, minute ventilation is tidal volume times rate. So if we have a tidal volume of 480 and we're trying to seek 9,600 on our minute ventilation, we've got to get a respiratory rate that's going to give us that. Okay? So if we did the quick math, it's going to be 18 breaths per minute. Now I'm going to kind of date myself a little bit, and this is one of the mistakes I used to make. I used to be under the impression that if we had our patients sedated heavily, we had them paralyzed, we had them on the ventilator, they were all comfortable, that we could maintain a respiratory rate very low, 8 to 10 breaths per minute. And I was very wrong. That was one of those approaches that I just learned as I went. I never had anybody teach me truly how to manage our patients to maintain eucapnia and not have the problems. So when I figured this whole calculation out and I learned this, it was like a big light switch came on for me. I promise you, if you utilize this approach, you will not have problems. So again, we have an 18 breaths per minute. We have 480 on our tidal volume. Injury approach is going to be tidal volume is your protection. We don't want to overinflate those lung fields. We want to maintain eucapnia and our minute ventilation by a higher respiratory rate. So in the injury approach, your standard approach is going to be lower tidal volumes and higher respiratory rates to maintain that eucapnia. Okay? And you're still getting great alveolar minute ventilation despite the dead space. So you're, like I said, you're at 8.1 liters per minute of minute ventilation. All right, so if we jump in and let's say have a DKA patient or we have an aspirin overdose patient, let's just talk about a DKA patient. Remember, DKA patients compensate by blowing off their CO2. They're trying to compensate in the respiratory side of their compensation. So they're breathing extremely fast, right? And so they're breathing, anywhere from 30 to 40 times a minute to try to compensate for that. Well, we also know that these patients oftentimes go untreated for quite a while, and when they finally seek medical attention, they're extremely sick. They're in severe metabolic acidosis. They have a very low pH, and they're very sick. So oftentimes these patients need to be ventilated, and they need to be intubated and put in the ICU. So how do we approach this? Well, number one, we cannot knock out their compensatory mechanism respiratory-wise, okay? And so I'll try to explain this real quickly. If you have a pH of 7.0 and you had a CO2 for this patient of 40, okay, and we decide we want to take their airway, and they're breathing at 36 times a minute, and they're trying to blow off that CO2. Well, remember, anything that the CO2 does, it's going to affect the pH. So they move in opposite of each other. If your CO2 goes up, your pH goes down. So we'll take this patient. Let's say we approach this patient, we RSI'd him, and we weren't real aggressive with our BVM management. We were breathing for him about 12 times a minute prior to intubation. What's going to happen? Well, their CO2 level is going to freaking climb through the roof. And remember, for every 10 points your CO2 rises, your pH is going to decrease by 0.08. So we started with a pH of 7.0. Now where are we at? We're at 6.92. And every 10 points we increase with our CO2, we're going to drop with our pH. We know a pH that plummets like that is going to lead to bradyarrest, bradyarrhythmias, and you're going to lose your patient. So we need to really, really take care of maintaining that compensatory mechanism. So how do we do that? Well, we just have to make sure that when we RSI them, that we're bagging them as quickly as they were breathing, number one. And we need to really have the most experienced clinician intubating the patient. We need first pass success. We need to get that ET tube in, and we need to continue with that same rate. So how do we do that? Well, like I said, you and I have 60 cc's per kilogram a minute of minute ventilation. When you're intubated, you have 120 cc's per kilogram a minute. And in a DKA patient, you're going to double that again. So at a DKA patient, you're going to be at 240 cc's a kilogram a minute. And if you did the math on that, or you just doubled what you had before, that's going to be a respiratory rate of 36 times a minute. Okay? So if you place this patient, you've intubated DKA-wise, you have a low pH, you have a high CO2, and you did everything perfectly, you need to place them on the ventilator, you need to put them on a low tidal volume. Because of the injury approach, you need to have them on a high respiratory rate of at least what they were before. Okay? I can't stress that enough. That you're going to kill your patients if you don't manage them appropriately. So maintain that compensatory mechanism. If you knock that out of your patients, you have to do that for them. Okay? So 240 cc's a kilogram a minute is what we need. Alright, so we're going to continue on. Your desired respiratory rate, again, we figured was 18, and that's going to give you a great CO2 level. Alright? We always want to keep our patients as close to eucapnia as we can. If they're a little bit hypercarbic, that's all right though. Okay? We just don't want severe hypercarbia. We don't want that. Okay, so let's talk about PEEP in these patients. Remember, PEEP is a good thing. I kind of hit on that before in podcast previous, and patients have an intrinsic PEEP of 3 to 5. Most ventilators will allow you to check somebody's intrinsic PEEP. And that can be very, very important in the obstructive approach, and I'll talk about that because of that auto PEEP aspect. So how do we check somebody's intrinsic PEEP? Well, they have, most ventilators, let's say the LTV 1200 has a inspiratory expiratory hold button. And so what you want to do is you want to do an expiratory hold, but you want to make sure the PEEP is turned off on the ventilator. You're going to do that expiratory hold, and it's going to tell you what somebody's intrinsic PEEP is. I'm a big component of, most of my patients in the injury strategy. I'm going to start with 5 centimeters of water of PEEP, and I'm going to go from there. It's going to also depend on your protocol. Most protocols have you stop at 10 to 15 on your PEEP. We'll also talk about different presentations here further on in this presentation where you need a lot of PEEP. Now, like I talked about before, PEEP scares a lot of people. People think that too much PEEP is going to cause, this massive pressure in the chest. You're going to have decreased venous return. You're going to have, aspects of similar to a tension pneumothorax. You're going to have compression on the heart. I agree to that with that, a little bit. All the studies that I've read, and obviously, I'm just a flight paramedic, but all the studies that I've read, and based on my practice and my use of the ventilator, I have never had a patient become hypotensive or bradycardic because of high PEEP. I've never had that happen. There's also the aspect of increased ICP. And again, I'm sure that there are certain cases out there that has happened. Just like any medication that we use, there's relative contraindications of side effects for all medications. And so you can say that for PEEP as well. I guess what I'm saying is PEEP is going to do so much for you, and you kind of have to weigh the pros and the cons. PEEP is going to be the quickest way to increase oxygenation. Remember in my first podcast where I talked about the glass door and the alveolar membrane and how we want to make that glass door bigger. We want to reach those dependent lung fields. We want to spread that out. And so the glass door aspect, make that glass door bigger, make it clean, and you're doing that by increasing somebody's PEEP, okay? I will say that most people will respond very well to 8 to 10 a PEEP. Most times you don't need to go above that. The patient that you're going to have to go high on your PEEP to oxygenate them is going to be the ARDS patient. But we'll talk about that here in a few minutes. So the whole point of PEEP is, number one, to improve VQ mismatch. We're trying to decrease shunt. We're trying to decrease atelectalis trauma. We're trying to maintain alveolar recruitment. Remember, your inspiratory part of your ventilation cycle recruits alveoli. Your PEEP maintains that recruitment. So always remember, PEEP is a good thing. A good analogy of PEEP as it relates to your alveoli. Imagine blowing up a balloon, those little itty-bitty balloons you blow up at a party, and how difficult that is to blow up. I know I have a really hard time even blowing one up. Well, once you blow it up, they're easy to continue to blow up. You usually don't have a problem. Well, that's kind of how alveoli are. You put an alveoli under PEEP. They don't want to open. You put enough PEEP on there, they stay open. Once they slam shut, if you turn that PEEP off, that's where you cause that trauma to that little alveoli sac. And so, they don't like to be slammed shut, and once you slam them shut, it's going to be very difficult to open back up. So maintaining at least a PEEP of 5 on these injury approach patients is pretty important. FiO2. So let's talk about FiO2. You can have low tidal volumes, and you can have a higher respiratory rate, and you can have a average PEEP, and use FiO2 and PEEP to your advantage. And so what it's called is it's called a PEEP FiO2 slide. And if you do this in conjunction, you're gonna greatly improve oxygenation. Remember though, oxygen is a biological toxin, and the body doesn't need high amounts. We live just fine on 21%. Okay, so despite your illness, despite the presentation, people don't need these high concentrations. Oftentimes we put these patients on 100% FiO2, and I guess that's all right for the short term, hours, maybe a day or so. But when you start getting into long, prolonged ventilator management, that's a bad thing. Remember, during normal partial pressure of 100 milligrams of water, 95% of molecules reduced to H2O, and 5% will be partially reduced to toxic problems or enzymes in the body. Okay, and that's what's called a free radical. Free radicals leak into the cytosol. They come out of the cell. Free radicals cause this huge cellular damage, and that's what's basically O2 toxicity. So we don't want that. That's, again, that aspect causes increased mucus. It causes inflammatory cascades that starts in the lungs, and it alone will cause problems where you'll have this huge inflammation process and cause ARDS. So again, on most of our patients that we approach, FiO2, keeping it at 100% for short periods is fine. All right, where do we want to keep our saturations? Obviously we were taught early on in school, I know I was, that a saturation of 96 to 100% was great. Well, as it's relating to critical care medicine, we kind of have to look at it a little differently. If we have 100% saturation, you don't ever know what your PO2 is, right? It could be 100, it could be 250, it could be 500. It's better to keep a O2 saturation, again, because we don't need this massive amounts of O2 to keep an SaO2 of 92 to 95%. That's more than ample to oxygenate our tissues. So, how do we maintain a good FiO2 and a good PEEP so everything kind of works together? Well, it's called the FiO2 PEEP slide. And the way to start it out is you put your patient on 100% FiO2, you put them on 5 a PEEP. Get them, all set up on the ventilator, wait a few minutes, make sure to see that you have an adequate saturation, between 92 and 95%, and drop that FiO2 down to 50% right off the top. All right, and once you do that, you're going to watch your patient. Look at your saturation. If your O2 sat drops a little bit, you're going to increase your PEEP, and you're going to increase your PEEP to 8. All right, and you're going to wait again for a few minutes. And so you have a PEEP of 8, and you have an FiO2 of 50%. Most likely, that's going to maintain a great oxygenation. If it doesn't, then you can increase your FiO2 to 60%. So now we have a PEEP of 8, we have an FiO2 of 60%. And you're going to keep going back and forth. At this point, then you're going to increase your PEEP to 10 if you still have a drop. And you'll have a PEEP of 10 and a FiO2 of 60%. If you do this and you have a lower tidal volume, higher respiratory rate, you have a PEEP of 10, you have an FiO2 of 60%, you're going to oxygenate your lung fields just fine, and this is going to be excellent for your patient. So use PEEP more to augment alveolar recruitment and oxygenation. It's going to be an excellent thing. You can refer to this. I'll put this on the website. It's called the PEEP FiO2 slide. There's a little chart you can refer to, and it's very excellent. Let's talk again about plateau pressure, and I know I am probably beating a dead horse, but this really truly is very important. So remember, we want to check our plateau pressure initially. We want to document that for a baseline, and we want to make sure we keep that below 30. All right. So if we start seeing a trend upward, then what do? Well, remember, we want to start slowly decreasing our tidal volume. And remember, in this injury approach, we started at 4 to 6 mils per kilogram, and we started at the 6 range. So we had a tidal volume of 480. Well, if we had a plateau pressure above 30, the first thing we're going to do is we're going to drop it to the 5 mils per kilogram. All right? And so that's going to be a tidal volume of 400. And we're going to go down no more than to the 4 mils per kilogram. Once we get to the 4 mils per kilogram and we still have a high plateau pressure, remember, we're going to now switch to a pressure-driven mode like pressure control ventilation or PRVC, pressure volume regulated ventilation. So one of those two. And remember, the reason why is because that's a compliance-based mode. It's again a little bit better of a mode for those sick baby lungs. And really, if you think about it, most of these injury patients that we're talking about with the low tidal volumes and the weak baby lungs, they would be just fine starting right out on a pressure-driven mode. It's going to be better for your patient. All right, so obviously we want to try to correct the problem. We just don't want to switch modes. We just don't want to drop our tidal volume. We need to try to make sure that it's not because of over volume based on our high tidal volumes. Even though we're starting at 6 mils per kilogram, that may just be too much and be causing excess pressure against the alveoli. So just correcting that may fix the problem, but there could be an underlying issue. Let's say you have a trauma patient, you've done a good assessment in the ambulance, and you've determined that you have decreased breath sounds on the left-hand side. We don't decompress simple pneumos. When you get in the helicopter, if you're a flight nurse or flight paramedic, remember your assessment skills are very limited now. You've got a helmet on, you can't listen to lung sounds. The chest is covered up. trauma patients need a lot of warmth. They lose a lot of body heat. So you really can't assess them as you would in an ER or in the back of an ambulance. So how do we know if these patients are deteriorating or if their pneumothorax is getting worse? Well, the plateau pressure is how you know. And that's why I always advocate putting a trauma patient that's intubated with potential chest trauma on a ventilator, because really, truly, that's the only way you're going to be able to 100% diagnose if somebody is progressing from a pneumothorax to a tension pneumothorax is with that plateau pressure. You can listen to or feel for chest rise, you can do all those things, but I can tell you from experience, you can miss things. And so looking at that plateau pressure, trending that, looking at it when you first put them in the helicopter, when you first put them on the ventilator, and let's say it's reading 25, you reassess it in 10 minutes, you may see that the patient's becoming a little bit agitated, or you may see trends in your blood pressure increasing, where they're in a lot of pain. They may be becoming more tachypnic, shallow respirations, and so you can do another plateau pressure, and you can identify if it's increasing, it's because they're tensioning. I can guarantee it. So at this point, you're going to decompress their chest. If you don't do that, I can tell you're going to get yourself into a lot of trouble. You're never ever going to be faulted for decompressing somebody's chest. If you've got to decompress both sides to rule it out, then do that. You're not going to ever get into trouble. That's the best option at that point for your patient care. Okay? So again, plateau pressure is everything. Reassess it, get a baseline. Make sure it stays below 30. Do whatever you can. Now, if you have a very sick ARDS patient, these patients can be extremely challenging. You may have plateau pressures that stay above 30 the whole time, and despite what you do, whether you're decreasing your tidal volume, you're going low on your tidal volume as far as 4 mils per kilogram, or you're placing them on a pressure-driven mode, your plateau pressure still may be high. So we just have to continue to document and look at that, and hopefully that'll start trending down as your good ventilator management corrects the problem. All right, things to remember. Again, tidal volume is your protection. We always want to do good sedation and pain management. I can't stress that enough. Try to stay away from your longer-acting paralytics in these situations. Good sedation, good pain management. I really feel like just giving vecuronium or rocuronium post-intubation wise is lazy. We should be doing other things so as to not do that. Watch your plateau pressures very, very closely. You want to maintain minute ventilation as close as you can to the 120 cc's per kilogram a minute. To recap that, remember, normal is 60 cc's per kilogram a minute. For you and I, unintubated, everything's good to go. For your intubated patient, you're going to double that because of the dead space that we lose. And then if you have a DKA patient or an aspirin overdose patient, you're going to double that again. And the reason why is we want to make sure that we don't knock out that compensatory process of somebody breathing and trying to blow off all that CO2. Remember, CO2 equals pH. If your CO2 climbs, your pH is going to fall. So that's why it's so important to maintain good eucapnia. pH is everything. pH drives everything in the body, so we got to really protect that. All right, so we've talked about the injury approach. Now we're going to talk about the obstructive approach. Remember, obstructive approach just has two aspects. It's got COPD and it's got asthma. And like we've talked about before, this is a ventilation failure. These patients have massive air trapping and auto-PEEP. They have very weak muscles, a lot of muscle fatigue, and they just can't expel that CO2. Remember in the first podcast, your inspiration process is very easy. Your chest contracts down, it draws air in, and it's a very effortless process. When you expel that CO2 or you expel that air, that's a more active process. It's harder to do. So when you have these COPD and asthma patients that are usually very frail, they don't have a lot of weight on them, it can be even more difficult, and they're very tired, and they've got all this air trapped. They've got these engorged alveoli. Okay, so remember what I said. You can check somebody's auto-PEEP in this situation. You can do an expiratory hold and see where they're at, see where their baseline is. You do that. You turn your PEEP off, and you do that, and you have an auto PEEP of 15 or 20, you know that they're way behind the 8 ball. Okay? All right, so we talked about in the injury approach that tidal volume is your protection. Okay? In the obstructive approach, it's just the opposite. We're not going to use high tidal volumes, so don't get me wrong there. We're going to use normal tidal volumes in the 4 to 8 mils per kilogram range, but our respiratory rate is going to be lower. Okay? And if you kind of imagine patients with COPD and asthma, they have higher CO2 levels chronically. They live at a higher CO2 level. They work off of a hypoxic drive, which is different from you or I, where we work off of that CO2 drive or those CO2 receptors in the medulla. And so these COPD patients, over time, these CO2 receptors become dead, and that's why they progress to a hypoxic drive versus a CO2 drive. All right, so the big problems with air trapping with these patients is this can obviously decrease venous return. It impedes the expiration process, and it really does impede spontaneous breathing. They just can't. You take all this air in, and their tidal volumes of what they're getting to their alveoli is becoming less and less and less. And you'll see this on the ventilator with the exhale tidal volumes. They'll start trending down. And in that situation that you've got a massive auto PEEP problem, and you've got to fix that. So, in these obstructive patients, your respiratory rate is your protection. Okay, if you have a patient set at 18 to 20 breaths per minute, like you would in the injury approach, that's not going to give them a lot of time to exhale. So we gotta protect that. So these patients, you're going to have a respiratory rate of 10 to 12. And the big thing with these patients is you want to make sure that they have plenty of time to exhale. So remember what I said in the initial podcast, your ID ratio on a standard adult is going to be 1 to 2. So for asthma, COPD patients, pediatric patients, ARDS patients, you want to extend that exhalation time out, and we want to do that by extending that ID ratio out. I see clinicians miss this constantly. They really forget to use this tool, and they'll adjust their respiratory rate to affect changes in their CO2, and they totally forget about the ID ratio. And remember, we want to maintain a good minute ventilation. That's essential. We've got to do that. So if you start messing with the tidal volume or the respiratory rate, you're going to affect that. So ID ratio is going to be a big thing in these patients. Again, respiratory rate is your protection. We want low respiratory rates. A higher respiratory rate, as in the injury approach, is not going to allow them time to blow off that CO2. As far as PEEP in these patients, they don't need PEEP. Remember, we want to check their auto PEEP. We want to make sure that they're already not overextending their alveoli, and so adding more PEEP onto that is going to be bad for them. We don't want that. So you can turn the PEEP all the way off in these patients, or you can have it at 2 to 3. So at this point, we just want to maintain as good of eucapnia as possible. Remember that they're going to have a high CO2 level already. Remember, like I said, you can affect change in these patients regarding your end-tidal CO2. That's going to affect the pH in a positive way. You're probably not going to have the drop in pH like you would or CO2 like you would in a normal patient, because they kind of live at that range. But at this point, anything is better than keeping them at a high 60 to 70, on their CO2, which, oftentimes these patients are that high. Remember, if you have a transfer patient like this and you can get a blood cast so you can get a baseline, that is always a positive. So where do we want to keep their FiO2? Remember what I said, too high of FiO2 is a bad thing. These patients don't need high FiO2s. It's not an oxygenation problem. It's a ventilation failure. So they're going to be well oxygenated. Their PaO2 is going to reflect that, and you're not going to have problems. We want to keep their saturation between 92 and 95%, like I said before. We want to make sure that We keep a permissive hypercapnia. Remember, they're going to stay at that high range all the time, so we don't want to drop them significantly. Just slow is good. It's all right. You're not going to drop their CO2 level from 70 to 35 to 45 like we're taught. And I see this mistake happen all the time. I see these people or these clinicians feel like they're going to get in trouble, and they try to drop these patients' CO2 down into that range because they feel like their chart's going to get audited. And I can tell you right now from experience that's not going to happen. So you just need to document that. Document what their normal CO2 range is, document what their blood gas is, and any improvement is good, okay? Because you may only have anywhere from 20 to 40, 45 minutes with these patients. You're not going to have that huge change. So at this point, we want to continue looking at our patient. We want to keep maintaining that plateau pressure. We want to make sure we keep the plateau pressure below 30. We want to keep checking that auto PEEP to see if there's improvement. All right, so remember, your ID ratio in these patients is going to improve the auto PEEP. Okay, so let's recap the obstructive approach. Respiratory rate is everything. Respiratory rate is your protection. Too high of respiratory rates is going to lead to not allowing them to blow off that CO2. Permissive hypercapnia is all right. So if you remember with our patients in the injury approach, we had a tidal volume about the same as we would in the obstructive approach, but we had a respiratory rate significantly higher. So that's going to give you a higher minute ventilation, which I said is essential to keep eucapnia. Well, in these COPD asthma patients where they live at a higher CO2 level, permissive hypercapnia is all right. You're going to obviously have a lower minute ventilation because they can't handle a respiratory rate that high. You still need to have a tidal volume that's appropriate, but you can't have that high respiratory rate. So you are going to have a lower minute ventilation. It is going to cause a little bit of hypercapnia, but that is all right. Our goal is to have them blow off that CO2. That's essential. So let's talk really quick about a few patient scenarios where you may have problems, tough patients. The first one I'll kind of read to you. You respond to a small hospital for a transfer out of the ICU. Initial report from the RN is the patient has a chronic COPD patient. Problems that he was intubated yesterday, current vent settings. So the patient's on pressure control ventilation, has a PEEP of 15, has an inspiratory pressure of 20. Remember that inspiratory pressure equals what their tidal volume is. So you're going to see that on the exhale tidal volume. That's giving them a tidal volume of 400. Their FiO2 is 100%. The respiratory rate is 32. And they're satting 88%. Okay? We're just going to kind of stop there. So let's look at those vent settings. We have a COPD patient. So what's the problem? Is this an obstructive approach or an injury approach? Well, excuse me, if you said obstructive approach, you're correct. This is obstructive. What is your protective part? Is it tidal volume or respiratory rate? Well, it's a respiratory rate because we want to make sure that we allow them time to blow off that CO2. What is causing, if you had a patient in this setting where you were getting exhale tidal volumes of 400 and maybe 10 minutes later you're now getting exhale tidal volumes of 250, 300, what's causing that decrease? Well, remember, auto PEEP. If you're not giving them enough time to blow off that CO2, that auto PEEP is going to increase. And if you remember, their respiratory rate was 32, and that's way, way too high. So we need to drop that down significantly. Drop that down to maybe 14 or 16 and just see what happens. See if they improve. See if that exhale tidal volume increases. So remember, obstructive approach, protection is your respiratory rate. Your PEEP, they had the patient on 15 of PEEP. We don't want any PEEP. They probably have tons of auto PEEP. So that's compounding the issue. All right, so we want to turn that PEEP off. Our FiO2, we don't have an oxygenation problem. They don't need to be at 100% FiO2. All right, so drop that down. Monitor their saturation. Why are their sats 88% then if it's not an oxygenation problem? Well, remember, you're not getting good tidal volume to all your lung fields. You've got all this auto PEEP, you've got all this pressure exerted against the alveoli. And I bet you if you took a plateau pressure for this patient, it would be through the roof. So we've got to correct the auto PEEP, we've got to decrease that pressure in the chest. If you ever have a patient that's COPD or asthma that you've had on a ventilator and they start to decompensate quickly, significantly, and it leads to bradycardia and hypoxia, what you need to do at this point, it's not a pneumothorax, it's not an equipment failure. The problem is they have massive pressure in the chest, they've got massive auto PEEP going on, and there's so much pressure that's not allowing them to even take or allow the ventilator to even give a breath. So you basically got a massive tension pneumothorax or a tension or a pericardial tamponade along those lines. You're not actually having that. So the key treatment for this patient is to undo the ventilator circuit from the ET tube. Let them exhale all that air that's trapped in the chest out. You don't want to listen to lung sounds. You don't want to do anything else. This is the only thing that's going to save your patient at this point. So you want to decrease that pressure. All right, really quick, patient number 2. You have a 50-year-old male patient that is in an ICU in a small facility, history of H1N1 flu with associated sepsis and ARDS. He's currently intubated and on the ventilator. You arrive there, you and your flight nurse arrive there. You don't get much of a report from the referring RN. They just seem to be way too busy. When you arrive, you find that the patient is on a CMV mode. Remember, that's controlled mandatory ventilation. Remember, I don't like that mode. Tidal volume of 600, respiratory rate of 12, FiO2 of 40%, and a PEEP of 10. Okay, so with ARDS, remember this is going to be the injury approach. It doesn't fall under the COPD or the asthma, so it's going to be an injury approach. And remember, with this injury approach, this is going to need to have lower tidal volumes. So let's say this patient is 80 kilograms. That tidal volume is significantly too high, so we need to drop that tidal volume down. Okay, that's one problem. Respiratory rate. Well, we need to maintain eucapnia. We've got to make sure that we're getting plenty of minute ventilation. If we're dropping the tidal volume, we've got to increase that respiratory rate. So I would drop the tidal volume down into the 480 range, 500 range, and I'd increase that respiratory rate up to 18 or so. FiO2 of 40%. Well, remember, with ARDS, you have a massive oxygenation problem. You have a massive shunt, and you've got that VQ mismatch. So we've got to optimize oxygenation. And at this point, it's not time to worry about those free radicals or anything like that. We need to get him oxygenated first, because that's what's going to kill him. It's going to lead to poor cardiac output, hemodynamic instability, etc. And his PEEP was at 10. Let's continue on, and I'll give you a set of vital signs. His vital signs were 76 over 40, heart rate of 130, SaO2 of 71%. So you can imagine, FiO2 of 40%, he's on a ventilator, and his saturations are 71%. So he's extremely, extremely hypoxic. You get a current blood gas from the receiving paperwork, and the pH is 7.10. All right, so that's going to be acidotic. A PCO2 of 60, so that's also acidotic. So we at this point have a definite respiratory acidosis. And you have a bicarb of 16, which is acidotic. So at this point, you have what's called a mixed disturbance. You have both or all three showing an acidosis. And you have an associated PaCO2, or correction, a PO2, right? So his oxygenation level is 40. All right, so they have him on an FiO2 of 40%, and his PaO2 is 40. Remember in podcast number 1 what I said about calculating what a desired PO2 is. Whatever FiO2 a patient has, you times that by 5. So they're on an FiO2 of 40%, times that by 5. Their PO2 should be, if he was perfect, everything was good, should be 200, and he's at 40. Okay, so that shows you right there how significantly hypoxic he is. And remember, this is going to lead to end organ death and overall mortality. Patient was also on a dopamine drip at 20 mics a kilogram a minute. Okay, his sedation was very poor as well. So what things can we do to correct his problems that may help him? Well, remember, ARDS is very tough to manage. They have very poor lung fields. They've got all this fluid, all this edematous stuff surrounding and inside their alveolar sacs. So we need to have good positive pressure ventilation. We need to have very high PEEPs in these patients. Remember, PEEP increases that glass door, increases functional residual capacity. It opens up those lung fields, dependent lung fields, and we need that to oxygenate our body. So those are some things we can do. We can lower the tidal volume. We can increase that respiratory rate. I would increase that FiO2 up to 100%, and I would increase that PEEP as well. And so you may say, well, a PEEP of 10 is giving you a blood pressure of 76/40. But remember, oxygenation equals cardiac output. And I really challenge you to look at this and try this. In these patients, if you optimize cardiac output, or correction, if you optimize oxygenation, you probably will have a positive effect on cardiac output. So, if you increase his PEEP and you recruit alveoli based on good ventilator management strategy, and you maintain that recruitment with good PEEP, and you oxygenate those alveoli, and you oxygenate the tissues, most likely your blood pressure is going to increase. Okay, what can we do though in the meantime? Well, you have him on a dopamine drip at 20 mics per kilogram a minute, and we know that that is a really high dopamine dose. Probably not getting a lot of benefit from that dose. He's already tachycardic at 130. So I would probably switch to a different pressor drug, or maybe a couple pressor drugs. So let's talk about that real quick. So you have 2 excellent or 3 excellent other medications that you can hang on this patient. The first one being Levophed, norepinephrine. Remember, it's an excellent drug in a sepsis patient. It's wonderful, and it's oftentimes even better when you piggyback that with dobutamine. Remember, dobutamine will have some vasodilatory effects as a side effect, and that's all right. It kind of works by relaxing everything, but it also causes a tougher contraction, so you have that inotropic effect. But it's always important to piggyback that with something else. You don't want to ever give dobutamine by itself, okay, because it needs a little help. So you would give a pressor drug like Levophed to vasoconstrict, and you would give dobutamine to have that inotropic effect. So that would be a great combination. You could also go with neosynephrine, which is a pure alpha agonist, and you're going to have that massive vasoconstriction effect. You're not going to have any relative effects in the heart rate or anything like that. It's not going to change anything there. So at this point, you're optimizing cardiac output. You're helping it along with those pressor drugs. You're trying to optimize oxygenation with a PEEP. And so how high do you go with a PEEP? Well, on this patient, I would keep going up. If you had online medical control or you had access to a physician, I would request to go up to 15, 20, 25 if needed. I had this exact patient, and that's what we did. And we kind of, jumped up, and we went up to 25 a PEEP eventually. And what happened was, and it taught me a lot, is it increased cardiac output by increasing oxygenation. We started with a SAT of 77, and by the time we got to the receiving facility, we had a SAT of 96%. We had him on a FiO2 of 100%. We had PEEPs of 25, and we had great sedation, and we actually were able to start titrating those drips down to where we had them almost shut off when we showed up at the receiving facility. So that really showed me a lot. It showed me that if you really take care of the oxygenation aspect, you optimize that, a lot of times over a short period of time, you're going to have positive effects in the hemodynamic status, which is going to affect everything downhill. You'll perfuse your kidneys better, you'll perfuse your brain, and that's what our body needs. So those are 2 tough situations, 2 tough patients. An obstructive approach, an injury approach that we talked about, kind of how to approach those. Obviously, there's other aspects of patient care. We talked about the drips and stuff like that. That's going to kind of conclude podcast number 3 of this ventilator management series. If you have any questions, you have any comments, or I said something wrong or whatever, please contact me at eric@FlightBridgeED.com. I will be putting a blog up, and we can discuss this via a blog if you'd like. And I just thank you guys for joining me. I'm really enjoying this aspect of education, and I look forward to hearing from you. Thank you.